I'm Dr. Kelly Kirksey, a holistic psychotherapist, and I am your facilitator for this evening's session. Her present vision is to educate and empower patients to seek appropriate health care in a timely manner. Currently, she is a professor at Lehman College in the Bronx, New York. And she says, I have worked as patient educator, community services for SCD patients, and the list is so long. Take notes about these amazing definitions that she's going to share with you this evening. And after she shares, give lots of questions and lots of comments, and let's talk to each other.
Thank you for that lovely relaxation technique. I also practice guided imagery with sickle cell disease patients, so thank you for that. Thank you for inviting me. So first, I'm going to just go through some terminology of sickle cell disease. I'm just going to give you an overview of sickle cell disease, which is a blood disease. Basically, it's a red blood disease. So it becomes sickled under the deprivation or the lessening of oxygenation. So when there's a decrease in oxygen, the whole cell becomes sickled, and then it forms problem. So that's where we get the name sickle cell. The first person that found this hematology problem, he decided to call it sickle because it reminds him of what you use in the grass to cut the grass, a sickled, if you know what that is. And so we got that name based on what happened when the cell loses oxygen. So when you hear the term sickle cell, it's referring to the condition or the shape that the whole cell has just lost into a sickle shape. And that causes pain and problem as the blood now tries to go through the small veins, and it causes severe pain in patients with sickle cell disease. Okay, sickle cell disease is under the big spectrum of what we call hemoglobinopathy. So hemoglobinopathy are diseases that affect the red cells. Sickle cell disease just happen to be some of those. So there's over 400 different types of hemoglobinopathies. So we have sickle cell hemoglobin SS, which is considered to be one of the worst type. Then we have hemoglobin SC, the next downward kind. Then we have hemoglobin SE, D, and it goes on and on. If a patient has a trait, which is a sickle cell trait, they will have a hemoglobin that is normal. We consider that the A hemoglobin with one of the abnormal gene of the sickle cell. Make sense? I can refer to that again. That gets complicated sometimes. So the A is always normal. That tells you have a normal cell. So AA is normal. SS is abnormal. AS is the trait, and it can also go in many different types of the traits. We have sickle cell thalassemia, minor, major, because it's part of the hemoglobinopathies that exist. Most of the time, when we talk about sickle cell disease, we're specifically talking about the red cell. Like cancer, cancer will have the white cells, and yet it goes through a different path. The red cells go through a different path as well. The reason why this disease is so horrific is that when we talk about the red cell, it has something that is so vital to life. It is called what? Oxygen, right? So the red cell carries oxygen. So red cells are cells that carries the oxygen throughout your body. Make sense? So when a patient that has sickle cell disease, they have an affected red cell, so they're always very tired, very limp, very weak. And so that causes them to become what we call in the medical term anemic. Their blood count is always lower. The normal blood count in the normal environment is about from 12 to 14. A sickle cell person will have from 5 to 7. Can you see the stress that that is putting on all the organs? Okay, so red cells are very, very important to understand. Another word that I would like to explain is one of the most problematic organs for a sickle cell patient. We call that the spleen. The spleen is what helps to get toxins out of our system. In a sickle cell patient, because the red cells are being hemolyzed and being changed from this nice round shape to a sickle cell shape, they go through the spleen at all direction, causing it to be clogged up. When the spleen becomes clogged, it's not able to work. So two things can happen. The spleen will say, listen, guys, I'm just going to give up. I'm sick and tired of being sick and tired of all these sickle cells coming through me. So we just stop functioning. And we call that what? We call it a splenectomy, but we call it a um, orthosplenectomy. That means it just stopped working. And then the other kind is when the cell just filled the spleen and it goes so big that it bursts. A patient can die within 5 minutes if they're not taken to the OR and they remove the spleen, and that's called a splenectomy. So two things will happen. The spleen will stop functioning. We call that a splenectomy or orthosplenectomy. And when the spleen is removed because it's getting too large, we call that splenectomy. So those are important terms to know when the doctor said, oh, we have to do a splenectomy on you. They're going to remove your spleen because it's causing too much problems. Now, the bad thing about removing the spleen for a sickle cell patient, it decreases what we call the immunity. So now these patients are at risk for what? Infection. They are prone to have all kinds of infection. The number one cause of death in a patient with sickle cell is infection, especially when they have a splenectomy or autosplenectomy, okay? Many times doctors will say, oh, you're in a sickle cell crisis. Well, that means that your whole red cells are under hemolysis. That means it's breaking down. And all the cells are being deprived of oxygenation. So therefore, this patient goes into severe pain wherever that avascular problem is taking place. And so therefore, that patient is in a sickle cell crisis. And the treatment plan for that patient is immediate fluid, and it's not 0.9 normal saline, it's T5.5 or half normal saline. Because of the osmolarity of the cell, we need this fluid to get into the cell, not stay outside of the cell, because then that will cause congestive heart failure. So we have to be very careful how we treat a sickle cell crisis. The second thing that they will do is start them on some form of pain medication to stop this severe pain that they're going through. All righty. Many times those sickle cell crises can go to any part of the body and call, let's say it goes to the hip. We call that avascular necrosis, AVN. So that means there's no blood supplies going to your hip because all the cells are trapped outside of the hip bone. So that bone is being deprived of what? Oxygen. There's no oxygen getting to this, we call it acetatabulin in your joint. And so that bone dies. As a result of that bone dying, it causes severe, the body is very amazing. So before anything in the body dies, you're going to feel tremendous amount of pain because the body's going to fight till it dies, okay? So that avascular necrosis is causing that patient severe pain because there's what? Deprivation of oxygen because of all the clumping of the sickle cells that won't allow circulation to go through the joints. And that can happen in any part of a sickle cell patient, the brain, the shoulders, the hip, the legs. If it stops at the legs and there's no circulation, we will see that this patient is being prone to what? Ulcers, leg ulcers. Again, no circulation going to the exterior, and so therefore the patient get leg ulcers. All right, and those are some of the words. I don't want to overwhelm you with all the words, but we can stop and ask questions, and I can repeat any kind of questions you have. I see I left one word out, and vascularity is when the vessel is no longer able to do its job. Okay, so we have these arteries and veins in our body, and they have the veins have valves to push the blood back up. Because sickle cell gets trapped within those nuances, it causes the body to the vein and the arteries to become stiff, and so it loses the vascularity of the circulation. So there's no further movement of cell, and that's why people will also develop leg ulcers in the lower extremity of their legs. Okay. Any other questions? I know I went a little fast, but I can stop. I was to answer questions.
Okay, thank you. So much. I was feverishly taking notes over here as you were speaking. But I want to open it up to everyone here in the room. What is something that you need Dr. Cassandra to clarify from what she shared? What are any of your experiences with some of the things that she mentioned? So let's take this opportunity to just raise our voices and share some of the experiences and to ask some questions about these terms and just the challenges that go along uh, with these issues. So feel free to unmute and step into the circle. And the first person to unmute, you might just get a prize. So come on in.
Can I ask you a question? You mentioned something about, I've heard the term frequent flyer.
Oh, yes, I forgot about my frequent flyer. Yes. Okay, so frequent flyer is a terminology that we believe in the sickle cell population was derived from physician and nurses or people within the healthcare. And this is said to be a patient that shows up every week because they believe they're addicted to opioids. So we call them, or they call them, I tend not to call them that, frequent flyers because they're always in the healthcare system seeking, they believe, some form of opioid drugs to stop the pain, which we are trying to work against. We are so against that terminology because what I have learned from working with sickle cell patients so long is that when this is the protocol for some hospital, a patient will come in, they will give them 3 shots of dilaudid morphine, Demerol, you name it, and then they will send the patients home. What the physician and the nurse do not realize is that what is going on is now the patient has this tolerance of up here. You send that patient home on nothing, it comes right back down and the pain starts again. So what I have always said in my writing and my literature, let's find out what's causing the pain. If you find out what's causing the pain will subside in many instances. Okay, infection. I have seen patient that has a WBC of 58 and they're just shooting all this opioids. The patient is screaming in pain, not to mention the few that died. And it's that they have a septic thing going on and no one is taking care of that, but they're giving them all this opioids. And then they call them frequent flyers because they come back in because they're not getting the treatment that they need. Okay. It's just a bad term, and we think it's a way that healthcare has stigmatized patients who have sickle cell disease when they come into the ER. So I believe Dr. Beverly's looking into that, and many of us in different parts of the country is trying to stop that stigmatization.
Oh yeah, that's a terrible term.
Mm-hmm.
And also it's just so sad to hear how people are getting labeled and not really getting treated to the full extent.
Exactly.
So much is being missed.
So
Yeah.
much is being missed. I mean, we had a 16-year-old that was in severe pain, and I'm saying, did anyone do a CBC? Anyone do a urine test? Because we know infection is like the first. Sure enough, the doctor gave the lethal dose of Demerol. He died. When the autopsy was done, he was septic. So
Oh,
many times when they're dying from sickle cell, it's not really sickle cell. I don't know if you remember before the 1986 penicillin trial, there was a lot of Black kids that were dying from what they call SIDS,
yes.
sudden infant death. When they go back and did a retrospective study, they found out that those kids were not dying from sudden infant death. They were dying from infection. Thus, the 1986 protocol was introduced that all children ages 5 and above must be on PenVK until they can survive. Remember, there's no spleen. What happened to kids? Even healthy kids are infected. So imagine a kid without a spleen at age 5. They're going to be getting every single illnesses that's out there. Okay.
Absolutely. Critical information.
Mm-hmm.
Would anybody like to share about any stories from your own life, or do you have any questions for Dr. Cassandra?
I have a question.
Thank you. You have the floor.
You mentioned septic, and I was wondering how would that present in someone's labs? And my next question is leg ulcers. You mentioned about the red blood cells dying. Is there a way to prevent leg ulcers or developing a leg ulcer?
Is there a what for developing leg ulcer?
A way to prevent it?
Oh, sure. Okay. So the first question is the labs you would see for a sickle cell patient. The normal WBC is between 4 and 10, 5 and 10. When it starts, I'm sorry, 4 to 5. If you see that WBC starts to get higher than that, patient will have a fever. Now, don't be fooled. A septic sickle cell patient does not necessarily will have a temperature. Okay? You know why? They can't even produce the heat because they have no spleen. Okay, they're immunocompromised. So therefore, don't just rely on a temperature. Take the patient to the doctor and have them do a CBC, okay, which is a complete blood count. You will check the neutrophils, the lymphocytes, the bands, and see what are those readings. Many times, if it's an infection in a sickle cell patient, the WBC will be over 10 or trending up past 10. And secondly, they will be feeling a little malaise. Their lips will look pale. Their finger bed will look pale. If you press it, it just will, the blanching, it won't get red once you press the finger bed. So they are having something going on. Remember, if they complain of burning on urination, they can have a UTI. Okay, especially teenagers, you know, check to make sure that they don't have a UTI, which is a urinary tract infection, sorry. And the leg ulcer can, I read an article by a physician that says that leg ulcers are going to be part of the life of sickle cell disease patients. Okay, and I kind of disagree with that. And what we need to do is when a sickle cell patient who is prone to having pain in their leg, when they're sitting, the leg should be elevated. That helps the blood returns back and causes increased circulation. If they feel that their ankles are extremely numb and there's no feeling there, try